Yeah, very good morning to all of you. I extend a heartfelt thanks to the organizers for having me here to speak on the topic of congenital nasolacrimal duct obstruction. So, as we had already seen before, the congenital nasolacrimal duct obstruction is understood best by knowing the embryology and its development, which was already spoken in the first talk. So we know that actually the ectodermal tissue in the groove between the maxillary and the lateral nasal process here actually forms a solid cord initially, and then later it gets canalized, and only at the end of the term or at birth actually you'll have a patent lacrimal duct system. So, whenever there is any failure of this canalization, and usually it results in a membranous obstruction at the lower end, that leads to the congenital nasolacrimal duct obstruction. In most of the children who are born, around 98%, the duct is patent, but only in 2 to 4%, there is a residual membrane at the distal end at the level of the valve of Hasner, giving rise to this condition. And the good part of it is that majority of it actually undergoes spontaneous resolution. And most of the time, we advise conservative treatment. And just by observing, we can note that actually the condition resolves. And hence, it is also more commonly seen in preterm births. So, this NLD obstruction can be either a simple or a complex NLD obstruction. Majority of the cases, it is a simple NLD obstruction where there is just a membranous block, and actually there is just a lack of resistance in passing the probe until the membranous obstruction is there, and it can be easily perforated. But in some cases, actually, it can be a complex NLDO, like this picture you can see here. Here actually the NLD, it extends up to the floor and lying lateral to the nasal mucosa. And when we do the probing with the Bowman's probe, actually we will not be able to perforate it, and it gives rise to a buried probe. Or sometimes the nasolacrimal duct can be impacted in the inferior turbinate, like this C or D, or it may actually open up into the maxillary wall, or there can be a complete absence of nasolacrimal duct. So, in conditions where it's a simple nasolacrimal duct obstruction, a simple probing will actually be the cure for the condition. But in complex cases, it requires more other procedures, especially endoscopic approach and other procedures, along with stenting or fracturing the inferior turbinate, etc. So it is more common in male preterm children, and it is usually unilateral. But in some cases, it can be bilateral, especially when it is associated with certain syndromes like Down syndrome, Klinefelter, Treacher-Collins, or other craniofacial anomalies, especially the cleft lip palate or hemifacial microsomia. The clinical features are presence of epiphora, discharge, matting of the eyelashes, along with crusts which are seen. And this is the most common presentation. Usually it is there at birth or few weeks after birth when the tear secretion starts developing. And sometimes they can present with a bluish mass near the medial canthus. This is also known as an amniontocele, dacryocele, or dacrocystocele. Sometimes they can have secondary infection, and it can present as dacrocystitis with surrounding cellulitis or even orbital cellulitis. And if there is a fistula, you can see that there is discharge or watering from the fistula. And some studies have shown that in cases where the nasolacrimal duct obstruction is unilateral, it can be associated with refractive errors and also anisometric amblyopia in that eye. So in some children, it can be a transient phenomenon, and usually it will be seen when the child has upper respiratory tract infection. And usually once we treat the URI, the watering and epiphora also subsides. The diagnosis is essentially clinical, but we can also confirm by doing the Roplast test the Jones dye test or the fluorescein dye disappearance test. You can see in this child in the left eye, the dye fails to disappear even after 5 minutes of instillation when compared to the normal eye where the dye has completely disappeared. In older children or when it's a complex nasolacrimal duct obstruction, or if it is secondary following any trauma or orbital fractures, then we can do a CT dacrocystogram or a dynamic lacrimal scintigraphy to identify the level of the obstruction. A little bit more about this condition, the amniontocele. So this is seen right from birth when the child is born, because actually it is the amniotic fluid which enters the sac and it gets retained by a non-patent nasolacrimal duct. And this gets trapped in the sac because of a ball valve mechanism which occurs at the common canaliculus where there is a valve of Rosenmiller. So the fluid can neither come out from the canalicular end and it can also not drain into the nose via the NLD, and it just accumulates and enlarges like this. So sometimes it can be in continuity with an intranasal cyst, and that can actually cause respiratory distress because the newborns are nasal breathers, and especially when it is bilateral, when the baby is breastfeeding, then they can actually have a respiratory distress. So this condition has to be treated as an emergency. And you can see here, this picture, there is an obstruction at this end as well as the distal end. And usually the treatment is probing. Along with probing, we have to open up the intranasal cyst and we have to do a marsupialization. A cruciate incision is made with a sickle knife with the help of ENT surgeon, and this condition is treated. So the general treatment of congenital nasolacrimal duct obstruction can be conservative in 90% of the cases, but the remaining we may have to go for surgical management. So the conservative management includes Krigler massage. So it is very important to do the correct technique. So most of the time, if we explain to the mother the right technique, and if it is done properly, we can see that 90 to 95% of the time, the conservative treatment is successful. So how it should be done is we can ask the mother to use either the index or the little finger with the nail trimmed, because sometimes when they are doing the massage, if the child moves the head, the nail can injure the cornea. You can have a corneal abrasion and it can get secondarily infected and lead to corneal ulcer. So we need to ensure that the nails are properly trimmed before the massage, and a firm pressure is applied just below the medial canthal tendon where the lacrimal sac is present, and by preventing the discharge coming out from the common canaliculus, we can actually give slight pressure near the common canalicular area and press from above downwards. So we have to give at least 10 compressions 4 times a day, and it is the pressure which is given on the sac which actually opens up the duct. So this is the correct way to do it. And you can see here actually the underlying anatomy of the sac and the canaliculus and the duct. So the pressure should be on the sac and common canalicular area. So there is no need to actually press over the duct. So this is how the compressions are given. And it can be done when the baby is sleeping or when the mother is feeding the child. So you need not give on the bone. So pressure on the bone and the duct will not be of any use. It has to be done on the sac. And the role of antibiotics can be given only when there is presence of purulent discharge and associated with conjunctival congestion, because most of the time actually it is the normal flora and may not have pathogenic organisms. So we had done a study in our patients where we cultured the organisms and we found culture positivity only in 27% of cases. And most of the time the organisms are either pneumococcus, pseudomonas, or also it could be the staph or epidermidis or staphylococcus aureus. And since majority of the time actually it is not pathogenic organisms, so we need not treat all cases with antibiotics because it will only increase the resistance, and when we need the antibiotic it will not work. And it's also important to remember that in case there is purulent discharge, you give the antibiotic only for 2 weeks duration. Once the infection subsides, the mother can continue doing the Krigler massage. And if the massage is done properly on follow up, there will be no discharge. So the child can have some epiphora, but because it is done sufficiently, no time is allowed for the discharge to accumulate in the sac, and actually you will know whether the mother has done the treatment properly or not. Otherwise, you can re-explain and ensure that it is done properly before going into the surgical management. So the success of the probing actually depends also on the age of the child. So a smaller child, actually, we don't have to do probing because the spontaneous resolution occurs in 95 to 80% of the time. Beyond 6 months, the success of spontaneous resolution comes down, the percentage of spontaneous resolution. And by 12 months, actually, there is no possibility of spontaneous resolution. So based on this data, uniformly, there is a consensus to go ahead with surgical management once the child is beyond 12 months of age. So the probing technique involves using this Bauman's lacrimal probe. So the probes are available in different sizes ranging from 0000 to 00000 and so on until the numeral 4. So why do we have so many sizes? That is basically depending on the age of the child, we decide on the size of the probe. So the smaller the child, we need to go for a narrower probe, but the bigger the child, we can go for a bigger size probe. And most commonly, since we do it at 1 year of age, the common size of the probe that we use is the 0 and 1 size, and the size of 0 probe is 1 millimeter. So you can just remember that once the probe size increases, the size also increases by 0.1 millimeter. And once the probe size decreases, the size also dimension decreases by 0.1 millimeter. So the procedure is to dilate the punctum, do a check syringing and confirm the regurgitation, followed by probing. And probing is done with two sizes. So initially a smaller size, and then we repeat with a slightly larger size to ensure that the tract opens up well. And you confirm the patency by doing a repeat syringing using a fluorescein dye. And some people advocate the use of endoscopic guidance to ensure that you are actually passing the probe in the nasolacrimal duct. Otherwise, it's a blind procedure. So if you do forcefully in the wrong direction, you may end up in a false passage. And intra-op, you may find that the fluorescein dye is retrieved in the nose, but the procedure will fail and the child will come back with a failed probing. So this is the technique where actually we are doing the punctum dilatation. So the probing can be done either from the upper or lower punctum, but usually we prefer the upper punctum because it is easy to guide the probe in the desired direction. So once the probe is placed in the nasolacrimal duct, the probe will stay steady in position. And once you do a spring back test, it will not wobble and fall down. Then you know you are in the nasolacrimal duct. Then we move the probe gently in the downwards, backwards, and lateral direction. So that is the direction of the nasolacrimal duct. So initially there will be a give way feeling when the resistance is overpassed. After that, the probing will be smooth. So this is the next size, the bigger size. Again, we are confirming the presence of the probe in the nasolacrimal duct, and then we move it gently in the downward, backward, and lateral direction. So it's very important to do it in the correct direction, otherwise you will end up with a false passage. Then we confirm by doing a syringing, and you can note that the fluorescein dye comes into the nose and the cotton placed at the nasal end gets stained with the dye. So sometimes in some children, we may consider doing it even before 12 months of age. So that is when it is an emergency causing respiratory distress in the presence of a dacryoceal, or if it causes recurrent infection and leads to chronic conjunctivitis, development of dacryocystitis or cellulitis, Or if the child is awaiting for a surgery, intraocular surgery, like congenital cataract or congenital glaucoma, because that time we need to first treat the uh, NLD obstruction. Otherwise, the child will end up with endophthalmitis because that discharge can go into the eye. Or if it is a syndromic child and it is not subsiding with conservative management. So now the success rates of probing also are good when they are done at an earlier age. If the child is more than 2 years, usually the success rate comes down, and the older the child, actually the success rate of probing also comes down. So for older children, usually more than 1.5 or 2 years of age, we go for probing with stenting. So this stenting, also known as intubation, is done for older children with complex NLDO, failed probing, and several stents can be used, either the monocanalicular or bicanalicular. The most common stent which is used is the Crawford stent. So this video actually I have taken from YouTube by Dr. Richard Allen. So here he's placing the Bowman's probe and confirming its position in the nasolacrimal duct by placing another Bowman's probe and seeing a metal on metal contact. So that is another technique. Just like the spring back test, you can do this. And this is the Crawford stent. It's a bicanalicular stent. So one stent is placed, end is placed in the upper canaliculus, and actually it's retrieved from the nose using a retrieval hook. So the hook is placed and the stent is retrieved into the nose. This is the other end which is placed in the lower punctum, and the second end also is retrieved from the nose using the retrieval hook. So the other eye actually is confirming the presence of any obstruction by doing the probing and syringing. So here when the syringing is done, the dye is coming into the nose. So he confirms that there is no nasolacrimal duct obstruction on the left side. So you can see here that the gauze is soaked with fluorescein. And then the ends of the stent are tied in the lower end of the nose, and it is left to retract back into the nose. So this stent is placed for at least 1 to 3 months, following which it can be removed by cutting the end at the punctal end and retrieving the knot from the nasal side. So in some older children where the repeated probings have failed, so usually probing can be repeated at least 2 or 3 times. Despite that, if it fails, we can actually try this balloon dacryoplasty. It's not available in many centers. It is more expensive also, but it can be used for these complex conditions where the nasolacrimal duct is dilated using a balloon catheter. Just like how we do a cardiac angioplasty, we have a balloon catheter dilation of the nasolacrimal duct. So for children more than 4 years of age, the probing also fails. We can go for the procedure which is done similarly in adults, which is the dacrocystorhinostomy. So we wait for at least 4 years of age so that the orbital anatomy stabilizes and the bones also complete development. And both endoscopic and external approaches have shown good success rate. So the take-home points are CNLDO is a common cause of epiphora in children. Most cases, 90 to 95%, resolve with conservative management, especially if it is a simple nasolacrimal duct obstruction. For persistent cases, complex cases, and older children, you have to go for probing with intubation or balloon catheter dilation and endoscopic guidance to rule out other nasal abnormalities which can be addressed. And dacryoceal with intranasal cyst should be handled with watchful measures and can be treated early. Endoscopic guided probings are actually coming up in vogue, and this has given a higher success rate because you know where exactly the probe is passing, and this has led to fewer children needing a dacrocystorhinostomy because of increased success rate. Thank you.